Thank you everyone for joining us today. We are presenting on metacognitive training for substance use. And this was made in collaboration between our lab, the Addictions and Concurrent Disorders Research Group, as well as the Vigo lab at UBC. And so we joined forces to make this module, and it was in collaboration with as well the Clinical Neuropsychology Working Group out of the University Medical Center of Hamburg-Eppendorf. So this project is kind of working towards something that Michael just presented in the keynote with Health Canada. So just to move on, us as presenters today, I am Kate Phillips. I'm working towards my bachelor's in psychology, and I'm the project and media assistant for ACD.
And my name is Marisha, and I'm working towards my Bachelor of Science in Behavioral Neuroscience, and I'm a research assistant here at the ACD group.
Yeah, and as I said, we have a lot of people working on this project, and two of those people helped us put together this presentation. So thanks to Jane Kim and Anne-Marie Goitan. So to get into it, we're going to describe MCT. So MCT is a form of psychotherapy, which really aims to give patients skills and strategies to change thinking and behaviors and contributing towards sort of dysfunctional thinking patterns and other behaviors, and as well giving some insight into their cognitions. And so essentially metacognitive means thinking about thinking. So that's what it is. And our version of MCT is solely focused on substance use. Previous versions have focused on depression, psychosis, and other disorders. But for this one, we have really developed it towards substance use disorders. And MCT is often done in group settings, but it can be done individually with great effectiveness. So this version is administered individually, and it is delivered in an online format. And as I said earlier, this module is developed to be administered through these online platforms. So within the Vigo lab, their population is student population. It is going on their Minder app, and it is students with psychological distress or risky behavior with substances. And then for RAMP, our target population, if you saw Michael's presentation, is high risk of overdose opioid users. So that is our population for this. And through this, we are hoping to really incorporate a lot of the features that the platforms have to offer. So it's going to incorporate media and other elements. So this is how we based our model. Essentially, substance use literature really informed the majority of the content. However, due to the overlap and similar nature of symptoms and challenges between substance use, depression, gambling, and psychosis, we derived some education and psychoeducation and exercises from these other modules, which I will go into detail more about. And so previous MCT research has found that it has been effective in improving positive symptoms and instilling insight into cognition and creating awareness of thought patterns and cognitive biases for those with schizophrenia. And it was quite effective. Even just an hour of training was enough to significantly decrease these biases in patients with schizophrenia. And so this was specifically for an individually administered MCT for psychosis. And this was essentially what we pulled from this was that we are going to be delivering this in an individualized format. And then also there were a few psychoeducational exercises and activities that we did take inspiration from MCT for psychosis. However, the majority of our foundation was from other modules. So I'll get into that as well. We created these other we created our substance use MCT with the foundation and the initial template within MCT for pathological gambling. And we tailored the psychoeducation and exercises to substance use through the literature search. And so we used pathological gambling because it has a number of commonalities with substance use disorders, such as translating understanding, assessing effective treatments, and preventative measures. These are the commonalities between the disorders that we really focused on. And then as well, MCT for pathological gambling was found to be an effective and highly acceptable form of treatment. It significantly reduced cognitive distortions and symptom severity after 8 weeks of group MCT for those with gambling tendencies. And in terms of the acceptability, there was a really high adherence rate. So around 70% of the participants completed the whole 8 weeks, and no negative side effects were reported. So we use this as our foundation for creating our module, as with supplementary evidence from literature. And so we're addressing a number of treatment gaps and barriers within creating this module. So as Michael has gone into in his other presentation, e-mental health has been an effective tool, and it does have long-lasting effects. So in one study on participants with depression, they went through a virtual CBT program, and they had a 46% recovery rate and a maintenance of good results at 8 months, versus a control group that did an in-person CBT, and they had a 26% recovery rate. Another really important point to discuss when kind of using all of these different modules and previous research as our background for creating this is that comorbid mental disorders are really prevalent among people who use drugs. And this is associated with suboptimal healthcare access and health outcomes, and also puts people at an elevated risk for overdose. And, you know, studies have found that Canadians with a substance use disorder and concurrent disorder are over 3 times more likely than those with only one mental health disorder to experience unmet mental health care needs. And this could be a variety of reasons, but some could be stigma, lack of provider training, and then as well as the difficulties that mental illness brings to navigating the healthcare system, which is awesome because, sorry, it's not awesome, but RAMP has a module that will address navigating the healthcare system. So we hope to incorporate that as well. And so through having virtual solutions, we want to, it's possible to have low barrier options that can be personalized. And we hope that these unmet mental health care needs are covered through our MCT for substance use. So this kind of brings us to one question that we'd love to get your thoughts on. So what do you think are some important factors for patient success in e-mental health care, and how can these be addressed? If you would like to type your answers into a chat or speak through the microphone, whatever you're most comfortable with.
I think that consistent frequency of sessions is really important.
Definitely. And for RAMP, we are developing a number of ways that we can incorporate this. And that comes from the system itself in like gamification elements and reminders and all of those things. But for MCT specifically, we are discussing a way to kind of suggest a schedule. So we definitely agree with you there. Are there any other ideas on how to keep people on their path towards success in e-mental health?
It seems like in the chat we have an answer from Morlin, who says being able to navigate the technology. That is a really great one to keep in mind, and definitely something else we've been thinking about in terms of the design and making sure that the design is something easy to follow. Like I know even, for example, trying to join a Zoom meeting can be really complicated if there's a lot of different links and a lot of different information. So we definitely have been keeping that in mind. And another great example is access to technology and Wi-Fi. That's something really important, especially for this population. People have difficulty with things like housing and meeting a lot of basic needs. So it's also definitely something we're keeping in mind when designing this platform.
Perfect. Yeah, sorry, I can't see the chat. So thanks, Marisha, for commenting on that. But those are really good points. And having it be easy to follow is actually something that was one of our primary goals. So I'm just going to advance to the next slide. These were our two kind of overarching goals that we discussed for this module. And one of the goals is to be engaging and interactive and easy to follow. So we definitely agree with you there, especially because patient retention is something that's very, very important for their success. And so through having media and having all these videos and different formats to administer the educational resources through this module, that's one way in which we hope to target this engagement piece, is having all of the media elements. And then hopefully in that we would address our other goal, which is to have them create an understanding for their dysfunctional thought patterns relating to their substance use. So moving on, as I said earlier, media is really, really important to us. So that is the main format in which, or there are many, many formats in which the content will be presented. And then another very, very important factor for us is the language that's used. We would really like it to be comprehensible at first glance so that it's, readily digestible and it doesn't have to be super complex. And so you can see that in how we've renamed some of our section titles. So we have various titles, Self-Esteem and Stigma that we address. We called one Explaining Situations, which is attributional style. We have Worrying and Strategies, which is about rumination. Attention and Thinking, which addresses a number of cognitive processes. And then as well, we have Relapse. And so they all follow a very similar structure that was inspired by the previous MCT modules that have been developed to cover kind of all the essential elements. So with that, I'm going to pass it off to Marisha to discuss the actual module content.
Great, thanks so much, Kate. So as Kate mentioned, we do have 5 kind of separate modules that all tackle different aspects, but we also understand that not every person is going to want to go through all 5 of them, given that all the content might not be relevant for them. So our goal with that in mind is kind of to have little introduction sentences to kind of describe the module content prior to actually starting the module, therefore allowing each individual to kind of tailor this experience to what will suit them best. So to start off with the first one, our first module is called Self-Esteem and Stigma. It's pretty self-explanatory. We're mostly going to be covering some basic psychoeducation on what self-esteem and stigma actually is, and also busting some myths, because we think that's something really important in actually allowing people to have good self-esteem. So some myths that we're going to be kind of taking a look through include things like whether drug use or substance use is morally right or wrong. Just because you might be someone who uses drugs does not mean that you're like morally like a bad person or you've made a wrong decision. Some other myths include things like people choosing to have substance use disorders or people making bad choices to end up here. Other things include people with substance use disorders are dangerous or might be cognitively impaired, and also that they might benefit from incarceration. So taking some time to kind of go through these myths and explain why they're actually not true is for us such an important part in helping people to kind of figure out these underlying cognitive assumptions that they might have about themselves. So next up, we have another quick discussion question, and we'd be really curious to hear your opinion on what you think are some ways that people with substance use disorders can feel supported when seeking help. And then also if you have any ideas on how stigma might impact some of these factors.
Let me check on one issue here. When you look at various belief systems people without substance abuse and psychiatric disorders express, then it's very clear that some of them are quite capable of being empathic and understanding about the ideology and the degree of free will or not free will that exists. But there's a large amount of the population that simply doesn't get it, who will argue over and over again, it's a personal choice, you don't have to take drugs, and so on and so on. And so if you want to convince somebody who is using that there is no stigma out there, they will tell you that there's a large number of people out there who are not about to be convinced. So what would you offer them as an explanation? Yes, there's a group of people who will support you, but maybe even the majority of the population doesn't get it.
Yeah, that's a great point. And I think with our module, we're not trying to tell people that you won't face stigma, because I think this population knows better than anyone that they will be facing a lot of stigma. But I think instead it's kind of to find ways to kind of make the situation better for yourself. So we'll present in a few slides, for example, some communication techniques. So if you're talking with someone who has a stigmatized perspective on this, it might be helpful to utilize some of these communication techniques in order to kind of better understand like their perspective and hopefully better kind of share your own perspective as well. And I see in the chat as well, someone has added a non-judgmental approach. Yeah, I think that's something really important. And that ties quite well into social support. And we know how important social support can be for people who struggle with substance use. So to learn a little bit more about how kind of stigma can impact social support and other ways to make people feel supported, a big one is that believing stigmas about yourself can lead to low self-esteem. So for example, even as we saw with the myths, a lot of people actually believe these kind of negative things about substance use and relate them back to their own experience, which naturally would just lead to kind of this spiral of lower and lower self-esteem. We also know that stigma leads to a lot of barriers in healthcare. So people who experience stigma, people who use drugs will often just feel kind of unwelcomed or even afraid to step into healthcare spaces or situations in which they'll be able to kind of feel that stigma more heavily. And then finally, bringing it back to social support, we also know that people who with substance use disorders really rely on having a good social support network. However, it can be really difficult to be reaching out and trying to gain the support if you know that your social support network might hold a bit of stigma against people who use drugs. So with that in mind, we have kind of developed a few communication techniques, mostly taken from different modules in MCT, as well as research on people who use drugs. And these strategies basically aim to help people who use drugs kind of experience and discuss their symptoms and signs and even their own experiences with other people in a way that kind of matches their own level. So for example, instead of trying to explain cravings as a strong need for a drug, you can kind of explain cravings in a way that maybe someone who doesn't use drugs might understand. So with that in mind, we're really keen on kind of trying to engage with you all as best as we can. So we have an opportunity for you to kind of do a little activity in which we would like for you to try to explain cravings to someone who believes the stereotype that people who use drugs lack self-control. All right, we'll give it maybe another 30 seconds to keep using Slido. And if you're having any difficulty, feel free to let us know, or you can also say your answer out loud or put it in the chat if that's easier. All right, so I think this answer is kind of exactly what Kate and I were looking for in terms of craving sweets and how a lot of us might crave sweet food, but that definitely does not mean that we have a lack of self-control. And I think that's a really easy way to kind of explain that to someone else who might also crave sweets, but someone who might not crave drugs in the same way that a person who uses drugs might. Nice. I think these answers are all great. And in the chat, we also have an answer from Jackie who says what it would describe to be like to give up coffee or to give up chocolate suddenly and then have to experience that. I think that's also a great answer. And as you can see, these are all ways that maybe people wouldn't typically think to explain drug cravings, but a way that might help the general population to kind of understand a little bit better in terms that are a bit more applicable to their day-to-day life. So thank you everyone for engaging with that. That was really cool to see everyone's responses. So we'll move on to some of the other activities that we have for the stigma and self-esteem module. So one that we know is really important in trying to boost people's self-esteem is by creating a positive self-concept. It can be really easy for people to kind of only see the negative things that are happening in their life, negative things they might see about themselves. So this activity can really help for people to kind of practice compassion for their own self and end up with a positive conclusion. So as you can see on the kind of table chart in front of you, there's basically an opportunity for people to go through each of these categories and pick out some of their own personal strengths. And we hope this is a good opportunity for people to kind of reflect on things that they might not typically think about. So for example, strengths they might have in their spirituality. Someone might not think of that as a typical strength that they have, but it definitely is something that's good to acknowledge and might help someone to come to a positive conclusion about themselves. So with that, we'll flip to the next module. And this is our explaining situations module, otherwise known as attributional style. So as Kate mentioned earlier, we definitely are putting a focus on language in this module overall, because we want to make sure it's really kind of easy to understand and accessible to all the users, which is why we chose to title it Explaining Situations as opposed to Attributional Style. So we'll first kind of cover a little bit of a basic of what are attributions. So for those of you who might not know, there are 3 general attribution styles, and this pretty much explains kind of how you perceive a situation. So for example, there's an attributional style on yourself. So that's kind of blaming or putting responsibility on yourself for that situation. So for example, if I got a really great score on a test, I might say, I studied really hard for that test, I'm really smart, so I deserve kind of the credit and the responsibility for doing well on that test. On the other hand, a second type of attributional style is on others. So for example, if I do really poorly on a test, I might say, my professor is really difficult, they made the test too hard, they didn't give me enough time to study for it, so the kind of blame and the responsibility is on them. Finally, the third type of attributional style is on the circumstance. So for example, I can say, my internet cut out during the test, so I was at an unfair advantage. It's not my responsibility, it's not the professor's responsibility, it was on just the situation that happened. So overall, what you want to try to do in order to kind of have a more holistic perspective is to have a balanced explanation. So for example, if I do well in the test, I can say, I did study really hard for the test. However, I also have a great professor and I happen to have really good test taking conditions on that day. So now, how does attributional style relate to substance use? So people who use drugs tend to have a bit of a biased attributional style. So what this basically means is, for this population, they tend to blame themselves for any failures that might happen. So for example, if we go back to that test taking situation, I would blame myself for failing the test. But if there were to be a success, if I did really well in the test, instead of kind of rewarding myself for doing well, I would perhaps put the responsibility for doing well on the professor or on the situation. This pretty much leads to people constantly blaming themselves for failures, but never taking the reward and the credit for doing well. And this can result in low self-esteem, sadness, withdrawal, and isolation. So we have a few activities that we hope can kind of help people to kind of surpass this biased attributional style and think a little bit harder about how they kind of place blame and reward on themselves. So this activity basically looks at all 3 of the attributional styles and asks people to think of an attribution for each of them on one situation. So in this case, the situation is that you relapsed at a party that your friends invited you to after a few months of being clean. So now in order for all of us to kind of try this together, we're going to be again using Slido. It's the same code as last time, so hopefully you kept your browser open. If not, we apologize, we should have let you know. Feel free to open up that browser again on the same code. So this time, if you could choose one attributional style of yourself, others, or the circumstance, and they kind of list an example for this scenario. And again, to remind you, the scenario is you relapsed at a party that your friend invited you to after a few months of being clean. I'll throw that in the chat in case anyone doesn't know it.
And feel free to answer via the chat as well. That totally works.
So it's Jackie, and I'd say if I was going to use others, then I might blame that there was other people using at the party, or I got triggered by people that I knew that I used to use with, or whatever. And then for myself, I might say, okay, I was feeling vulnerable today. Perhaps, I didn't take enough time for myself. I was feeling, super vulnerable or super weak. And coincidence could be, I was at a party where people were using and I wasn't expecting that. I don't know. That's it.
Absolutely. Those are all perfect examples. I think that's a really good way of looking at it.
Can I add one?
Absolutely.
I would probably spend some time with the individual to talk about the consequences of it. What's the meaning of the relapse? And I always found it important in my teachings to talk about abstinence violation effects. So if a smoker smokes a cigarette again after, let's say, 6 months of not smoking, yes, you smoked the cigarette. You can't go backwards and say it didn't happen. However, that does not make you a smoker again. So you can be a non-smoker right after this episode and hopefully stay one.
That's great. That's really good to, keep in mind. And I think that also is something that ties into the balanced attribution. Hopefully people, as they go through this activity, will realize that, it's not just because they used one time does not mean that they are a drug user. They're not someone who has relapsed necessarily. There's a lot of other steps. And it seems in the Slido, we have another answer. So thank you for that. I think, again, these are all really great responses. All right, so here's kind of a little answer key per se, which as you read, you'll realize are a lot of the responses that we got from your comments. So we're hoping that people will go through this activity and kind of fill it out themselves. But in case they aren't able to come up with any examples, we'll also be able to give a few examples to them as well. And we'll probably have a few other different scenarios so people can find ones that really speak to them and kind of speak to their personal lifestyle. All right, so moving on, we have our next category, which is worrying and strategies. So this one is really thinking about your kind of intrusive thought patterns or rumination that might be problematic. So a lot of the psychoeducation focuses on rumination and why people ruminate and kind of how it can be positive or negative. There are a lot of different studies that kind of point in different directions with rumination, but overall, it tends to increase negative mood, increase negative emotional experiences, and it isn't especially helpful in kind of figuring out any type of problem solving or way forward. So we kind of talk a little bit about that in the psychoeducation section, and then we move on a little bit to how worrying and specifically rumination might impact people differently with substance use. So it's pretty common for people who use drugs to have intrusive thoughts about substance use. And it can be really difficult to kind of control these thoughts. So people tend to try to suppress them. So they just think, I never want to think about this again. Whenever the thought comes to my mind, I'll just push it down. Unfortunately, this is not an especially effective strategy because if you've ever tried to not think about something, you'll realize that you probably just think about it more than you expected. And it kind of just keeps on coming back. So that's not very effective. Instead, it's really important to be mindful. So we try to introduce some mindfulness activities, and having a better sense of kind of your own cognitive control through mindfulness has actually been proven effective through various studies in ways to control your thoughts. So some activities that we have include observing your thoughts without actually engaging with them. So that's why we have the little image of the plane, because you're supposed to just kind of think of your thoughts as something that's passing through, not necessarily something to engage with or put too much thought in, but it's just something that passes by and you just let it go. We also have some breathing exercises and sensory grounding. And you can see an example of a sensory guiding a little infographic on the bottom right-hand corner, in which you kind of just go through different senses that you're able to experience and think about them a little bit to kind of ground yourself. Lastly, we also say that delayed rumination is a possible activity that can be helpful for controlling thoughts. This pretty much just means if you are finding yourself kind of thinking about something too often, you can kind of just push that to a later time. So you can say, I don't have time right now to be ruminating. I'll push it back to 8 p.m. tonight. Then I'll give myself 20 minutes to kind of think over the situation a little bit more. So next up, we actually have another activity that, or some other activities that we think are really kind of beneficial here. And this is thinking a little bit about triggers and their consequences. So often when people ruminate, there are certain kind of maybe people or situations or moods that might trigger this rumination, and that can kind of lead to more spirals and out of control thoughts. So in this case, we thought the best way to kind of introduce this theme was through a case story. So when we use case stories, it's kind of found throughout RAMP and throughout the MCT module. We tend to choose one person who is kind of relatable to the users in this section and kind of go through what they might be experiencing. So an example that we might want to use for the trigger example is, say, a person named Rebecca who finds herself ruminating a lot, and she often finds herself not being able to get these thoughts out of her head. She really wants to have better control of her thoughts, but is realizing that simply suppressing her thoughts over and over again is not effective. So what this activity would do is kind of walk through a day in Rebecca's life and allow her to kind of figure out what triggers. So for example, maybe it's talking with a specific individual, maybe it's going to a specific place that is constantly kind of triggering this rumination. So another activity that we have is called attention training technique. So overall, this is basically an opportunity to kind of focus your attention on different spaces. So we won't have time to go through the audio guide today, but what it really means is that there's different, it's like an audio clip with different sounds in it, and you're able to kind of direct your attention to different sounds in order to kind of get a better control of how you're feeling. This actually is a technique that has been proven effective for depression, schizophrenia, and other anxiety disorders as well. So that's why we are keen to use this as well in hopes that it does have effect for people who have substance use disorders. And with that, I'll pass it off to Kate to do a quick introduction of the attention and thinking module.
Yes, so for the attention and thinking module, we renamed it but it really addresses a lot of cognitive processes that are relevant to our populations. So we go into, for the psychoeducational portion, we go into a number of terms, and then we ask them also to reflect on these terms and how they might experience this in their own life, or like how it's relevant to them. We talk about attentional bias, working memory, impulsivity or to be impulsive, inhibition, and executive function. And if you're confused why I have a Where's Waldo image, if you recall the Where's Waldo activity where you just have to find Waldo in this busy scene, it's just to illustrate the idea of attentional bias. So essentially, like, out of all of the clutter in our perceptions, one thing might be really, really salient to us and appear more frequently than others. Even if it's not in our minds at the moment, even if it's not the task at hand. The task on hand here is to find Waldo, but you might just like notice certain elements repeating throughout the image that are just very, very salient to you. So that's just sort of to illustrate the idea, but we're going to have videos discussing this, as we will for a lot of the other psychoeducational portions. It's probably going to be discussed through a video. And just as a discussion question, if just, someone could just give a quick example of how any of these relate to substance use. Perhaps for the sake of time, I will move on, but if anyone has anything else to say about this, you can totally add it in the chat as we continue on. So how we related this to substance use for our audience is that we talk about specific attentional biases and how this creates drug cues for their preferred substance. So this is like a strong association between that substance and their surroundings, or their specific mood or feelings, or sometimes both. And so essentially this, through these like continual reinforcements, your brain makes shortcuts and bypasses executive functioning. And this is how we explain to them that by bypassing their executive functioning, it can affect your decision making and your goal setting abilities. And it might make it quite hard to engage in flexible thinking. And so being able to like see from other perspectives or appraise situations in different ways. And it might draw your focus away from other thoughts. And so these are the things that we focus on to explain to them. And then we also move on to a number of activities which are heavily founded in literature on substance use and how these habits can be practiced that can improve on goal setting abilities, problem solving, and whatnot. So we have exercising, getting a good sleep. We've found some card and mobile games that really help with working memory and planning. And then we also encourage people to use the problem solving module on RAMP. And we also encourage them to use the goal setting tool on RAMP, which is a system on the platform that you can use to kind of set goals and keep yourself on track. And then with gamification elements that will come, there's going to be reminders and deadlines for people to practice these goals on a time frequency that they want to. But it's pretty important for us to kind of always be linking people back to other modules or other tools so that they're reminded that they're there for them to use, and how kind of all of these things are very intertwined and incorporated together. And so Marisha is going to summarize the last module for us today.
Thanks, Kate. So the Relapse module is kind of unique compared to the other 4 modules because it's pretty specific to people who use drugs. And we actually got a lot of this content from the gambling module, given that people also face relapses in gambling, but this is maybe a little bit less common in other modules like psychosis, depression, schizophrenia, and topics like that. So the first part I'll briefly touch on is the psychoeducation. It's pretty basic covering of things like what is relapse, when do relapses occur, how do things like stress influence relapse, as well as going over a few terms like early warning signs, triggers, and cravings, just to make sure that everyone is on the same page. So next up, we have kind of a little bit of a section on how relapse relates to substance use. So here we talk a bit about the prevalence of people relapsing, of people who use drugs. And something that we think is really important to acknowledge is that relapses are common. Between 40 and 60% of people relapse within the first year after their treatment. And recovery is definitely not a linear process. It can have lots of twists and turns and ups and downs. We also acknowledge how difficult it is because relapses are so common, and it can be difficult for people after they experience their first relapse to really feel motivated to get back into treatment. So kind of helping people understand that it's not about their personal willpower, but it's a lot of things that are kind of influenced by your biology and psychology that can be difficult to overcome. So really just acknowledging how difficult this is something that we know is so important for overall success in our modules. So in terms of activities, we have a few different ones that we hope people will find beneficial. The first one is called imagery training, and this has actually been used in people who have alcohol use disorders. And basically, you just kind of visualize yourself getting rid of the problematic substance in your life. So for example, with alcohol, you can actually picture yourself holding a glass of your preferred alcoholic beverage, and then you picture yourself throwing it across the room and you see the glass shattering, and all of these images and kind of visualizing yourself in the scenario can actually help people who are suffering with alcohol use disorders. So we're hoping to make something similar to that for people who use injected drugs. We also have a section on trigger management, and you can see that in the top right corner on the little table that we have there. So this kind of allows people to go through some triggers that they personally have and ways for themselves to kind of prevent perhaps being exposed to this trigger, as well as positive and negative consequences that might arise on behalf of this trigger. And then finally, we have kind of an emergency management plan. So what this is another little table that we hope people will fill out upon seeing it. It basically gives people an opportunity to write down some emergency contacts and some emergency coping strategies in case they feel some early warning signs or strong cravings come about that they think might lead to a relapse. The reason that we think this is a really beneficial activity is because we hope that people will fill it out kind of in a more neutral or calm moment when they see it in the RAMP platform. But when they actually need it, they don't have to go through and kind of make it on the spot. They'll already have access to this emergency plan. So it'll kind of prevent them from having to think too much in this moment of panic, but instead to be able to use those to call a trusted friend or family member, or perhaps to use some of those coping strategies. So next up, I'll be talking a little bit about the next steps that we have both with the RAMP platform and the MCT module. So in terms of MCT, our next goals are kind of to finalize the content and also kind of the format of how we want this to be delivered. As Kate has mentioned throughout the presentation, we have numerous different media avenues that we're looking to explore, things like videos, audio clips, images, and things like that. So we're going to spend the next little bit of time creating a lot of this media ourselves to make sure that it is really appropriate to our audience. After that, we're hoping to upload it to RAMP and also get some user testing on the entire platform. So the feedback that we get from MCT specifically on RAMP will be able to kind of be integrated and used in a second version of RAMP that we hope will be coming out at some future point. And that's actually all we have for the presentation today, but thank you very much for your engagement. We've really enjoyed being able to share our work with you. If anyone has any feedback, questions, or comments on the content we've presented today, we would be more than happy to hear it. We'll be able to stick around in this room for the next 10 or 15 minutes, I believe. And we also have our email addresses on here if you have any further questions.
So does it mean you're opening up for Q&A?
Absolutely, yes.
Okay, I'm not entirely clear to what degree this is strictly self-help and to what degree a therapist could more directly interact. Because my experience certainly is that while these are all excellent strategies and reflecting sort of the latest in sort of psychological therapy science, the application is often a very tedious and detailed kind of a process, and individualization is a big trick. So for example, when I've worked with smoking cessation, people need a large repertoire of alternative behaviors if they sense a craving. If they only know one thing to do and that happens not to be available, well, they're going to relapse. So you do need to spend time with people of finding 5 or 10 different ways how they can distract from the craving. Is there an opportunity within the program for a therapist to develop that for the individual and the individual circumstances? Because that, to me, is critical for maintenance.
Yeah, that's a great question. Kate, if you have anything to add, feel free to jump in. I think this platform, RAMP as an entirety, was kind of developed to be done just by the user themselves with minimal kind of additions from like therapists and physicians. And the reason it's structured like that is because we know that people who have substance use disorders often face such long wait times in order to get into any type of like therapist or program. So this is kind of supposed to be like a bit of a middle bridge per se. So people are able to do these exercises while waiting to get more professional help. And that's why we chose to not have any therapists intervening at this moment in time. I think if the opportunity arises, we definitely would be really keen on including therapists to individualize this program further. But just kind of given the format of the platform right now, we don't think it's an immediate possibility.
Yeah. And also one thing that we are considering incorporating into MCT specifically. So the clinical neuropsychology working group in Germany that we are collaborating with, they have a ton of these programs for various psychological disorders. And one of them, they have a self-help MCT for OCD. And this format that it's in is really, if you recall, like choose your own adventure books, you know, how you get to a page and you get to choose where you go next type of thing. They have a very similar structure to that, but it really asks the user to check in with themselves. And if they don't meet a certain criteria, they aren't supposed to move on. And so there's a number of like really, really effective like points that they ask the user to check in with themselves. And if they don't agree with a statement, or if they don't, you know, meet their own criteria, and it is based off their own perception, but they're asked to redo the section or reread an activity or whatever else. So that is something that we're considering for the format as we move on into later versions of this module.
I think it's really important because a number of years ago, we did a clinical trial with the self-help stress management strategy for high blood pressure. People just don't do it. It doesn't matter how good the program was. They nod their heads, they agree. And then we had at a halfway point, a therapist call in to check how they're doing and give them a chance to ask questions about where they might have gotten stuck and to motivate them. The great majority didn't even touch the material. They'd agreed to it. I mean, obviously they signed on to be randomized into the trial, but they just didn't do it.
Are there any other questions from the audience or feedback or things that you think we can incorporate? So far, what we've had has been really good. So I've definitely learned a lot.
Hi, can you hear me?
Yes, we can, Stephanie. Hi.
Okay. All right. Hi. My question is, at the beginning, you showed a slide and it was saying you have to dig deeper. Now, is the program does that? Does it help to do that? Because on your slide, you were mentioning about like a lot of things that could affect the reason, I guess, why somebody would become addicted to substances. And so I was wondering, are you guys digging deeper and helping to resolve trauma and stuff like that? Does it allow that or something else?
Yeah, so for RAMP as a whole on the platform, there's definitely a number of modules that do address underlying factors. And there's a ton that we're going to be creating in the future as well, specifically for trauma. That is one portion of the platform that is definitely very important to our lab. And that is something that we are putting a focus on. So there's going to be a number of different kind of streams that someone can go down. And trauma is definitely one, because we do know that it is prevalent in a number of people who do use substances. So yeah, that's a really good question. Marisha, I don't know if you have anything else to add on or clarify.
Yeah, I think Katie, you really summed it up well. I think what MCT focuses more on is people's current state of mind, as opposed to kind of what previously might have led them to become someone who is using drugs. So I think, it's kind of dealing more with currently, how are you perceiving situations? What is your current level of stigma experience or self-esteem, in order to kind of move forward, as opposed to thinking too much about how they got to this point. But I definitely do agree with Kate that there are numerous other modules on the RAMP platform that have been developed or will be developed in the future that will be tackling more of the kind of digging deeper aspect.
Well, I just want to say thank you. Looks like, promising approaches, and obviously there's always a chance to do more and more development and digging in and alternative paths, but it all looks very promising.
Thank you.
Thank you.